is yours or our branding teams?
Good afternoon, everyone. 31st of May happens to be No Tobacco Day, but still lung cancer happens to be the most common cancer globally. We know that our focus is on non-communicable disease, most commonly being cardiothoracic ailments, but the second most common non-communicable disease is cancer. Over 20 million cases are diagnosed annually globally, which is 2 crore new cases of cancer diagnosed annually. Almost 10% of these cancers, slightly more than 10%, are only lung cancer. So lung cancer happens to be one of the most dreaded ailment one can have. In spite of the newer developments, there's a lot of things to be explored. And we want to dwell today independently on how it is diagnosed, how do you suspect lung cancer, and what can be done about it. So good afternoon once again, and let me introduce you to my team today. We have Dr. Vivek Javli. Sir is one of the leading cardiothoracic surgeon of not just Karnataka state, but the entire country. And we are really honored to have him here today. We have Dr. Sonali Shinde. She's a radiation oncology in our team at Fortis here at Bangalore. Dr. Venkatesh Babu is a surgical oncologist who's working with us for a long time, taking care of all subspecialties in surgical oncology. Dr. Dhyaneshwar is a medical oncologist, also takes care of hemato-oncology. Dr. Nagarjun is oncopathologist. He has been trained in one of the best centers in the country and takes care especially of oncohematology aspects, oncology and hematology aspects, and pathology. Pranati is our psycho-oncologist. Welcome, Pranati. Dr. Madhusudan is the head of radiation oncology at Fortis Bangalore. Dr. Sharat Pengali is a surgical oncologist, senior surgical oncologist, who again takes care of all aspects of surgical oncology, including thoracic. Dr. Vivek Padigal is an extremely well-known pulmonologist in the state of Karnataka. Thanks so much, sir, for coming over today. So let me start with Professor Dr. Vivek Javli, sir. So what is the known incidence of lung cancer globally and in our country?
You told just now 2 crore lung cancers. In our country, the correct incidence, nobody knows because we don't have data. But it is more common than we think so. So whatever figures we see from the Western world are their figures. Our figures, we really don't know.
It still happens to be one of the commonest malignancies.
If you say top 10, top 12 cancers,
yes,
this can be counted among them. And you said dreaded because it's in a difficult organ.
Right.
B, it always tends to come late. And when it presents, they may not be surgically fit. Those who are not surgically fit are not destined to live long. So they will come at the late stage.
Dr. Sonali, what is the incidence in our country reported? I mean, do we have a statistics what is prevalent?
We have Globocan 2023 data, in which it is lung cancer. In the incidence in India will be is the fourth most dreaded cancer in India, and mortality wise also it is about the fourth most dreaded cancer. Whereas in males it is leading about at the second rank. And in India, the incidence is around 72,000 new cases are detected per year in both the male and the female.
So that's quite a lot
Yes.
of cancers, and also especially mortality seems to be so high.
That, it is like about
unlike cancers like breast.
One question: the 70,000 is a registered
Yes,
cancer
reported.
registry. Now, from your bandwidth and experience of this country, what part of the iceberg is this?
So you are very right, sir. We have underreporting. We can definitely state that as hospital-based registry, the numbers are much larger, and there's a lot of underreporting. Not just tobacco-related, non-tobacco-related cancers are also huge numbers, especially younger women.
My hunch is that if you look at India, that mostly lives in non-cities, this could be just 35% of the iceberg.
Agree, sir. So, Dr. Sonali, what are the risk factors of lung cancer?
The risk factors, the mainly is the smoking is the biggest risk factor of lung cancer. About 80 to 90% of cancer is lung cancer is mostly by smoking. The other risk factors are like the other risk factors are environmental tobacco smokers that like smokes, that is secondhand smoking, air pollution related, which can be outdoor air pollution, which is because of combust from the cars, combust from vehicles and fossil fuel burning, and indoor pollution like using of wood and fuel and everything. There is occupational hazard, which is the second most common risk factor, in which there is asbestos exposures, and people who are exposed to asbestos like in automobile industries, buildings, construction in industries and all, and that increases the risk. 3 times risk is there for lung cancer in these people. And the third thing is radon exposures. So in natural environment, exposure of radon, that is the third most common thing. And the other in patients, in old patients who have already received radiation, like in Hodgkin's lymphoma, there is a risk of 2 to 3 times risk is there for development of lung cancer. And
So what you're saying is even smokeless tobacco is very important. And
yes.
whether you talk about hookah or you talk about other alternative preparation, even they have added risk. We think that if we use an alternative, probably the exposure will be less. Even e-cigarettes have an increased
Yeah,
risk of lung cancer. And
yeah.
then, of course, for women in our country, even indoor pollution,
Yes.
whether it is chula or it is coal burning, can also increase the risk.
Risk.
Very
Radon
rightly
is,
said.
radon is a new awareness.
Yes.
A footnote on advice to engineers on constructions.
Yes. And especially in our country, in Karnataka, sir, the North Karnataka has so much of mining.
Fine.
And it should be a normal occupational advice given, in which patients after certain years should regularly assess their lungs
Screening has to be done
again.
regularly.
And also untreated pulmonary tuberculosis, who have had refractory pulmonary tuberculosis, sometimes may require
And
rework
one
up
more
for
thing,
looking for
interstitial
malignancy.
lung disease and pulmonary fibrosis, bronchiectasis, they also increase the risk of the of
Yes.
lung cancers. And obesity is another this one.
Very
And
interesting. Yes. So, what are your thoughts about resistant tuberculosis and having incidental diagnosis of pulmonary adenocarcinoma?
We've known for a long time that a certain subset of people who've had TB can develop cancer. In the past, we call it scar cancer or scar carcinoma. I'm not aware whether MDR TB itself would cause a greater incidence of cancer, but in theory, it makes sense because we tend to get a lot more destruction, a lot more damage to the lung, which could in turn lead to cancer, which is very sad because having MDR TB is almost like having cancer. And to get another disease after that would be very sad. So, in this situation, I think prevention for both would probably be a good thing. But there's definitely an increase in lung cancer with people who've had tuberculosis in the past. And there's an increased incidence of TB in people who smoke. So I think this all may be interlinked as well.
Also, I guess sometimes treated as tuberculosis without proper evaluation is another aspect which we see in rural India.
Definitely. I think many times patients will come to me on tuberculosis medication saying they have TB when in fact they have cancer. So it's definitely something that needs to be on our radar. As, I think it gives the argument that we really should try and prove tuberculosis with sputum studies and such. And if you're not able to establish the diagnosis, perhaps try do imaging, try and do a proper diagnosis. Another interesting thing that we've had, Dr. Niti and I especially, we had people with both TB and cancer. And whenever you're immunosuppressed or you have cancer, you can develop TB as well. So this reactivation of TB can be an issue as well, which makes it quite challenging. But we have a very good multidisciplinary approach in our hospital, and we tend to have very good outcomes with these patients.
Yes. So, Dr. Venkat, what do you think are the common symptoms of lung cancer? What are the commonest and what are the other common symptoms which you come across?
As we know, lung carcinoma is the fourth most common carcinoma in India, but still most of the patients presents to us in the advanced stage. Nearly 60 to 80% of the patients comes to us in the advanced stage. Very few patients, like around 5 to 10% of them present in the early stage, stage 1. Usually they will be asymptomatic. They will be detected based on incidentally based on scans done for other reasons, or if we are doing screening for the purpose of detecting lung carcinoma in the smokers. In advanced and locally advanced cases, the most common presentation will be persistent cough. And along with the persistent cough, patients may have blood in sputum. And other than that, difficulty in breathing can also be present. And in very advanced stages, like in the metastatic setting, patients may present with disease spread to the other organs like bone pain, which can present in around 20% of the cases. And lung carcinoma can also spread to the brain, where patients can present with a headache. It is also seen in around nearly 20% of the patients. And advanced malignancies can have loss of appetite, loss of weight, other features along with the mentioned features.
So basically, you summarize that it could be lung-related symptoms or it could be spread-related symptoms. It could be early disease with different symptoms and late advanced disease with different symptoms.
Yes.
So in the same, you used a very interesting word called screening. So let me ask Dr. Sharat, sir, what are the screening recommendations for lung?
As of now, the recommendation is that people who are aged 50 to 80 years of age, who have smoked more than 20 pack years, and who are either currently smoking actively or who have quit smoking only in the past 15 years, the recommendation is that at least low dose CT scan should be done on an annual basis. These are the subset of people
So basically,
who will
identify the
benefit from here.
high-risk
Correct.
population and then
Correct.
annual CT scan.
Correct.
So I think our job as oncologists is also to create awareness of how to catch these early stage lung cancer so
Yes.
that the results are better.
Yes.
So I'll go to Dr. Vivek Patikal, sir. As you started saying, how would you actually diagnose a lung cancer?
Well, typically we would get a history like you mentioned, and probably the first thing we would do for most patients is to get a chest X-ray. And based on the chest X-ray, probably the next step would probably be to get a CT chest. A CT chest is probably the most definitive diagnostic imaging that we do to kind of understand where we're going to proceed to make a diagnosis. Typically, we do we consult the radiologist, we talk to the oncologist, we do something called a multidisciplinary type of interaction where we kind of decide what is the next step we do. So based on what is on the CT scans, there's several approaches we can do. One of the common things that I do as a pulmonologist is something called bronchoscopy. It's an endoscopy of the lung where we would take a fiber optic device, kind of like the gastroenterologists use for the stomach, but much smaller. And we go into the lungs and we look for anything which is within the airway. And that we can biopsy directly. For something which is not in the airway, which is adjacent or slightly away from the airway, we can use something called endoscopic ultrasound, where we have an endoscopic device connected to an ultrasound, and we can image these tumors and biopsy it. Actually, this has come a long ways in the last 10 years, and we're getting incredibly good yields and good results in this. Anything more peripherally can be approached either by a bronchoscope using, again, ultrasounds or what we call X-ray guided or fluoroscopic guided, or sometimes we do it from outside, what we call a CT guided biopsy. Now, the CT guided biopsy would go outside under local anesthesia, typically by a radiologist, and would introduce the needle into the area. Sometimes when the cancer has spread outside the lung, we may go for the bone or liver or lymph node and get the diagnosis as well. So after that, we typically will try and get a good amount of tissue. Now, this is very important because everything hinges on this now. And not just the first step of making the diagnosis, but we have several steps after that. I'm sure we'll be discussing that.
So lovely, sir. Very comprehensive summary. You said it is a central location. You would treat, you'll diagnose it differently if it's peripheral, or if it is spread to another organ, you would possibly use a different technique. So we loosely talk about liquid biopsies very often, Nagraj. What is the role of liquid biopsy, or what are the applications in lung cancer? Can be used for diagnosis?
Yeah, as of now, as Sir was beautifully explaining that the importance of biopsy, that is a foremost, very critical procedure that has to be conducted before you label a person suffering from a lung malignancy. Because with this, the entire line of management will be decided. And now, as he was explaining, uh, uh, all these procedures with Sir was telling CT guided or bronchoscopy guided, there are actually minimally invasive or a bit invasive procedures. So sometimes the patient has to be prepared and suitably taken into the procedure room and taken a suitable biopsy. So all these procedures, what we were discussing, they are kind of minimally or invasive procedures. Now, as Madam was asking about liquid biopsies, what is this? This is a very interesting investigation that has come up, in recent years, where in regular practice, it is it is routinely used into the management of this lung malignancies. So what is liquid biopsy? Is nothing but a non-invasive procedure. You would be surprised to know that it is nothing but you're just drawing your 5 ml or 2 ml of your peripheral blood, as how you're giving it for routine investigations for your thyroid levels or blood sugar levels. In the similar manner, you're just drawing your blood and submitting, and the blood is being evaluated for the presence of malignancy in the patient or not. So this liquid biopsy is commonly used to monitor the treatment. So once the patient has been confirmed with CA malignancy of lung, the patient has started with treatment, and now you want to know whether the patient is responding to a therapy or not. So each time taking a biopsy is really distressing the patient. So in that way, just simple non-invasive technique of drawing your peripheral blood at frequent intervals will actually give you an idea as to whether the patient is responding to the treatment or not. So this is the most significant role which liquid biopsy is taking center stage. And another point is that sometimes if the patient is really not comfortable to be diagnosed of, for the invasive procedure, is not in a fit state, we can actually, in fact, try liquid biopsy at the initial stage to know whether the patient is having lung malignancy or not. But the only limitation of this at the time of diagnosis is that the patient, the sensitivity rates are quite low. In the sense, if the report comes as negative, it does not mean that the patient is not having malignancy. Probably the tumor is not shed into the blood. So there you will have a chance of, falsely, missing out the patient who's really suffering from lung malignancies. So that is the reason where we advocate doing at least a minimally invasive procedure at the first go. And once you're confirmed and during a follow-up, you could, just with a simple non-invasive blood investigation, you can know how good the patient is doing and how well he's faring.
So lovely, Nagarjun. Actually, you said that a very small role in diagnosis, but subclassification also is enhanced with liquid biopsy, because you can molecularly subclassify with certain targets which you treat better. And the third important thing, which very importantly you highlighted, was molecular monitoring. Whether you can see if the tumor burden was high, which came down, and therefore you can see whether the patient responded. Early responders, early progressors also can be classified. So that's definitely an emerging role and the area where we as oncologists are looking towards. So Sharat sir, let me ask you, how do you actually stage lung cancer, and how do you, how would you want to treat them separately, whether it's early stage or advanced stage? I would let Madhu also take the same question after you.
Um, like any other cancer, lung cancer stage, most of the solid organ cancers are staged by a system called TNM staging. T stands for the primary tumor, that is the tumor within the lung where the cancer has started. The N stands for the regional lymph nodes, that they are the lymph nodes in the chest, in the middle of the chest. And M stands for spread of the cancer to organs other than the primary organ of origin of cancer. Like for example, lung cancer spreading to liver or to bones, etc. So this is called the TNM staging system, which is the most common staging system used for most of the solid organ cancers. So once there has been already a detailed discussion about how we arrive at a diagnosis of lung cancer. Once the diagnosis of lung cancer is confirmed, the next question is the staging workup. So for almost all non-small cell lung cancers, it is like mandatory to do a PET CT scan, whole body PET CT scan, in order to stage the disease. And then that is how it is done. In case of small cell lung cancers, we also might add an MRI of the central nervous system to rule out CNS metastasis, because PET scan is not that good for CNS evaluation because of the background activity or uptake of glucose. So it is either a whole body PET CT scan in case of non-small cell lung cancer, or whole body PET CT scan plus MRI brain. So this is how we stage the lung cancer. Once the stage is ascertained, then we go for the treatment as per the stage of the disease. Dr. Madhusudan.
Hello, hi. The lung cancer is not just one entity as we used to think before, Raj. Today, especially in the last 10 years, a lot of developments has been happened in the lung cancer, especially with respect to the molecular classifications, subtypes, what we see today. So when it comes to the treatment of lung cancer, as like the other cancers, we always use a multimodality approach, including the surgical oncology, thoracic oncology, medical oncology, radiation oncology, pathologists, genetics, because nowadays even the genetics playing a major role in the treatment of lung cancers. Not only other than the stage 1, in stage 2, 3, and 4, genetics playing a major role. And before we consider a treatment of lung cancer, there are other parameters we should consider before we decide on the treatment. First thing is the stage of the patient, the stage 1, 2, 3, 4. Next comes the pathology, whether it's a squamous, non-squamous, small cell, non-squamous, like neuroendocrine component. And then comes the genetics of the patient, whether the tumor is expressing any molecular subtypes which we can target specifically. We can use targeted therapy, we can use immunotherapy. And then we also have to consider the performance status of the patient, which is very, very important before we consider any treatment in any type of cancer. In stage 1 cancers, options include surgery versus radiation therapy. In stage 2 cancer, surgery, chemotherapy, and radiation therapy. In stage 3 cancers, there are a subset of cases where resectable or non-resectable will be there. It's a combination of approach. We use sometimes chemotherapy first, sometimes radiation first, or combination of chemotherapy and radiation first, and then we do surgery. Or we use chemotherapy and radiation as a definitive, and we consolidate with immunotherapy or targeted therapy. In stage 4 cancers, it's mainly a systemic treatment, and we will be using the radiation or the surgical modality as and when required. Thank you.
So Dr. Madhu rightly said, you will look at biologic fitness, the molecular subtype, and the stage. So based on these three combination, you would decide what modality you would want to choose for.
Yes, ma'am.
So Vivek Javli sir, what are the surgical applications? When you will do surgery on a lung cancer patient?
Lung cancer or any other cancers are now not approached by one specialist or one person. It's always a team approach. And what does a medical oncologist think? What do the radiation oncologists think? And then the surgical strategy emerges. All the commonest cancer is non-small cell carcinoma. Less common is small cell carcinoma. Then there are some other exotic cancers. The non-small cell cancer is much amenable for surgery. If it is seen in early stages where the size is small, there is no spread to distant organs, no spread to the lymph nodes, then it's a very plumb sitting kind of a case which can be given a very gratifying long-term surgical result, and their 5-year survival could be as high as 67%. If the cancer is detected early, then we need not sacrifice the whole lung, which used to be the practice in the past. Today, we can do it always endoscopically or robotically. Almost everything can be done robotically. and we could just remove that lobe or even a segment of the lung. If there is a nodal spread, which should be diagnosed preoperatively, then we could do the nodal clearance. If the and the cancer could be at the periphery of the lung or at the root of the lung. Periphery of the lung again goes into the whatever I said till now. But if the cancer is small, early stage, but it is near the root of the lung, it becomes a very difficult problem. And the most of the time, we may end up removing the entire lung. Removing the entire lung post-operatively, the care has to be very top class. Patients who have come late and who have a distant metastasis or lymph node spread, then the adjuvant therapy becomes very important, and the oncologists and radiation therapists will take care of that. We may prepare and say that this debulking has to be done, then we could do the same thing again just now. But robotic and video endoscopic surgery are now playing a big role. In these kind of cases, the 5-year survival rate will drip down very dramatically. And the small cell cancers, surgical gratifying result is almost a fable, a fairy tale.
Thanks so much, sir. Excellent, sir. Actually, you classified it so well, and I mean, made everybody understand. So, as you started the topic, Dr. Dhyaneshwar, can you please add on what are the applications of chemotherapy in early stage lung cancer?
So it's called the two entities. One is a neoadjuvant and adjuvant. So neoadjuvant means before surgery, we will give the chemotherapy and reduce the tumor size, and it's easy for surgeon to remove the tumor. So next entity is adjuvant therapy. So what is adjuvant therapy? Post surgery, we will give the chemotherapy. So questions will come here. So surgically, you removed all the tumors. Why you want to give again chemotherapy? So there are two entities. One is micrometastasis, macro. So macro means what we are seeing and what we are seeing in the scan reports we removed. So what we are not seeing, it is called micrometastasis. The tumor cells can enter into the circulation. It can go to anywhere in the body. It can metastasis. To prevent that metastasis, we have to give chemotherapy. So nowadays advanced treatment came. So we are giving chemotherapy 4 cycles followed by immunotherapy for 1 year. So and another thing is we will check, as Madhusar said already, genetic background we have to check, like EGFR, all positive, anything you have to check. If anything positive comes, we can give oral tablet form for 2 to 3 years.
As you brought out rightly, Dr. Madhusudan, you mentioned about radiation. So please tell us about radiation in early stage lung cancer and also possibly in advanced stage lung cancer.
Early stage, when it comes to the stage 1, when patient is, even though it is resectable, but the patient is not medically fit to undergo the surgery, then radiation, we say nowadays, is equally as effective of surgery as if like doing a lobectomy also. Without doing a surgery, we can have the equal survival rate with stereotactic radiotherapy. That is called SABR, or stereotactic radiotherapy, wherein we give just within 3 to 5 days of treatment, we can give the results as equally as the surgery. Okay. So when it comes to the adjuvant setting, suppose adjuvant setting means in a curative setting, patient has undergone the surgery. So what is the role of radiation therapy in the adjuvant setting? Say, for example, in a adjuvant setting with N1 disease, ideally, we are not supposed to give radiation therapy in a N1 disease, because the post-operative adjuvant therapy, especially radiation therapy, adds to the morbidity of the surgery. So we avoid radiation therapy in a N1 disease, T2 or N1 disease, unless there is a positive margins, either a R1 or R2 resection. In a N2 disease, nowadays that we follow the adjuvant chemotherapy as a standard practice. Adjuvant radiation therapy in the N2 disease will be given, where the surgeons face that the adequate lymph node has not been removed or multiple stations lymph node has been found. Okay. Suppose if you want to give a radiation therapy in the adjuvant setting for a margin negative N2 disease, it should be a sequential, something like give chemotherapy first and give radiation therapy later. In a positive disease, positive margin disease, we give concurrent chemotherapy as standard of practice nowadays. In an advanced disease like stage 3 and stage 3 disease, where we feels that it is surgically not resectable, we go with the combination of chemotherapy and radiation therapy, which will be followed by a consolidative target therapy or immunotherapy.
Dr. Thyanesh, how do you manage a stage 4 case? You said almost 80 to 85% will come in advanced stage. And this is a predominant lung cancer subset. And how will you manage? How would you subclassify them? How would you decide management?
Before starting the treatment for stage 4 disease, we have to consider multiple parameters. One is patient parameters and is tumor parameters. So patient performance status, comorbidities, any other failed organ failure it is there or not, we have to check. And performance status main thing. Second thing is tumor factors. So we have to check immunotherapy markers and any targetable mutation like genetic factors. Well, we have to check. Once we finalized everything, so based on that we can treat the patient. So treatment available are only immunotherapy we can give based on the immunotherapy markers, or immunotherapy plus chemotherapy, or only chemotherapy or targeted medicines. So particularly only immunotherapy, if immunotherapy markers are expressed very high, or elderly people particularly 70 plus or 80 plus, so immunotherapy will be first choice. So if immunotherapy markers are not expressed much, but still we can give immunotherapy plus chemotherapy. If targets are positive like EGFR, ALK, ROS, that time we can give targeted medicine. It specifically act on the tumor, and it is a tablet form, not chemotherapy and all intravenous form. That this targeted medicines are tablet form. They're easy to take and no need of hospitalization, and monthly once follow-up is required. But apart from this targeted immunotherapy and chemotherapy and all, hospital administration required. It is a IV form of therapy.
Going forward in the same, I mean, in the OPD, this is a usual scenario that I have a 75-year-old person in the house and he's diagnosed with lung cancer. And I'll come and say, well, he has diabetes, hypertension, he's taking cardiac medication for ischemic heart disease. And now he has been diagnosed with lung cancer. Can I treat this person? Would you call him medically unfit?
Age and comorbidity is not a contraindications for any form of treatment. Actually, what we have is the fitness of the patient, performance status of the patient. There are some patients who comes, actually the performance status may be down, maybe because of the cancer itself. Suppose somebody comes with a fracture due to pathological fracture or a spinal cord compressions, the patient will come with a wheelchair, or patient might come with a stretcher. Actually, that doesn't mean that we should label that patient as a performance status 4 or a low performance status. We not treat. So we should consider if that performance, what is the reason for the low performance status. And no performance status, no comorbidity, even diabetes, hypertension is not a contraindication for any treatment. Nowadays we see patients, like it's not like 5-10 years ago where we used to see stage 4 lung cancer, that means like a death sentence. Actually, we have so many patients stage 4 cancer, just they are on, especially who are expressing the molecular method, just with one tablet they're more than 5 years today, and with a good quality of life.
Sometimes treatment may actually improve their fitness. So
Yes,
it's hard
definitely,
to say that who is medically unfit, or if unfitness is actually technically related to the disease.
Yes.
And when disease treatment can actually make them so much better.
Yes.
Dr. Venkat, I mean, I again have this family who keeps on saying, well, we had nobody in the family having cancer. So is there actually a genetic etiology or genetic correlation to lung cancer?
Yes, ma'am. As we said, out of 100 patients who have lung cancer, we can attribute nearly 80 to 85% of the cases to tobacco smoking. Okay, remaining 15% of the patients, they may not have actual smoking history. Like sometimes non-smokers, they'll be developing malignancy history. Okay. In lung cancer, we can see few familial clusters of malignancies. That is, as in if the first degree relatives, like more than 2 first degree relatives, or if there is an early age of onset of lung carcinoma in the family, we can see an increased risk of malignancy in the current patients. But like in other malignancies, there are no definitive identified genetic mutations which can be attributed to the lung carcinoma. But there are some mutations like a gain of chromosome 5p, chromosome 6, 7, 8. All this can be associated with the increased risk of lung carcinoma.
Yeah, as you rightly said, familial clustering could also be sometimes similar environmental toxin,
Yes.
which is exposed to the entire family, which
Yes,
is causing
like
cancer.
the family living in the same environment, they'll be exposed to the same environmental factors. And even sometimes passive smoking can also cause a few cases of lung carcinoma. There is nearly 3% risk of developing lung malignancy in case of passive smoking. And With the smokers, it is around 30%. 30% of the 30% lifetime risk of developing lung carcinoma will be there in smokers.
Sharad sir, how do you follow up a case who has been treated for lung cancer? And what exactly follow-up means? I mean,
So once, not only for lung cancer, once a patient completes treatment for any cancer, we need to keep him on close observation, which means periodically he needs to consult his primary treating doctor, whoever has treated him for the cancer. The idea of asking the patient to come for repeated checkups even after the whole treatment is completed is that sometimes cancer can recur, because cancer basically spreads in the form of cells. These clusters of cells, not even the best scan in the world can pick up these clusters of cells. So there could be microscopic disease in patient's body which cannot be found out by the clinical examination, or it may not produce any symptoms, or it cannot be picked up even by the best scans available as on today. And these clusters of cells can grow over a period of time and they can produce symptoms again. So one should not feel that once the treatment is over, everything is done and then we can go home for good. It is not like that. We need to come for regular checkup. The idea of another thing is, when we keep the patients on regular follow-up, the chance of picking up an early recurrence is high. Suppose 10 patients of lung cancer we treat, all of them we keep on follow-up. 1 or 2 out of 10 patients, if they are going to have a recurrence, the doctor would want to pick up that recurrence early so that it is easier to treat. This holds good not only for lung cancer but for almost all cancers. So the idea is not to miss a recurrence and to pick it up early whenever possible. If there is a chance and everything goes in patient's favor, still there could be a chance of cure in that particular patient if it is a isolated site of recurrence. Having said that, when it comes to lung cancer, the follow-up schedule that has been advised is at least first 2 years post completion of treatment, patient is advised to come for follow-up at least once in 3 months. The subsequent, that is the first 2 years, every 3 months. From the 3rd year to the 5th year, we generally ask them to come at least once in 6 months. And once 5 years is completed, then we keep them on follow-up at least once in a year, lifelong. Because the term cure has not been clearly defined in cancer patients. Suppose somebody survives for 5 to 10 years post completion of treatment, we only assume that probably is cured. But many times, sometimes we see recurrences even post 5 years after the treatment. So, but having said that, we can't ask the patient to come very frequently, but this is the recommended schedule for follow-up of cancer patients.
thanks so much, sir. Dr. Sonali, could you speak about smoking scenario in our country and what are the benefits of quitting smoking?
Smoking usually tobacco smoking causes about 70 to 80% of lung cancer incidence, and this one about 83% in the men, and about 19 to 20% in the female. Also, there's a high risk of lung cancers just because of smoking. And even passive smoking, that secondhand smoking, there is about 2 times increased risk present. And people who have quit smoking and have even smoked for once in lifetime, there is a 15 to 30% increase in risk of developing lung cancer in the future. And people who quit smoking, cessation of smoking is important here. And as in, there is a decrease in risk of developing lung cancer by about 40% in patients who have quit smoking for about 7 to 10 years, and 12 if they have there's a quit of smoking by about 15 to 20 years, then there is about 70% decrease in risk of developing lung cancer. And so even in between, even if they have just smoked for one time also, there is again a rise in risk. So cessation of smoking is a very important thing.
And not just cancer. I mean,
Yes.
you cut down the risk of several other things,
Other
starting
things,
from
yes.
pulmonary to cardiac
Yeah.
and general fitness.
It's all or none.
So, Dr. Venkat, could you talk about smoking cessation clinics and what are the intervention if a patient comes to us and says he's been smoking for a long time and now he wants to quit smoking?
When we talk about the most common cause of cancer related death, it is lung carcinoma. But when we talk about the cause which is responsible for most number of deaths related to the cancer, it is tobacco. Tobacco is related to the multiple cancers, including lung carcinoma, gastrointestinal carcinoma, urinary bladder carcinoma, all that. So in our country, nearly 10% of the population is using smoked tobacco products, and nearly 20% are using smokeless tobacco products. Nearly total 28% of the population are exposed to the tobacco smoking. So smoking cessation is important in preventing these diseases. Okay, when it comes to tobacco cessation, there are multiple ways to prevent it. The two important methods are the pharmacological therapies and behavioral therapy. In the pharmacological therapy, we use something called as nicotine replacement therapy, and many other drugs are available. When we see tobacco related carcinomas, it's not the nicotine which is causing carcinoma. It's the other products which are associated with the tobacco smoking, like tar, polycyclic aromatic hydrocarbons, and other chemicals which are present in that tar, which is responsible for the lung carcinoma. But nicotine is the product which causes addiction to the smoking. It is not the direct cause. So in tobacco cessation, we can use something called as nicotine replacement therapy. In that, there are multiple forms are available, such as nicotine patches, nicotine gums, nicotine chewing gums, nicotine sprays, etc. will be available. And there are some drugs called like varenicline, bupropion. All the drugs can be used in case of tobacco cessation. In nicotine replacement therapy, we use what is called as long-acting nicotine replacement therapy along with the short-acting nicotine replacement therapy. In long-acting, we usually start with using nicotine patches, which contain nearly 21 milligrams of nicotine. If it is not sufficient, we can give additional patches as well. And for the short-acting nicotine replacement therapies, we can use gums, lozenges, and sprays. All that will be available. And behavioral therapy also plays an important role in cessation of smoking.
So you brought out the right thing, the psychological intervention. And we have our psycho-oncologist here who actually specializes in smoking cessation clinic as well. Please talk about psychological interventions and how would I proceed with smoking cessation comprehensively.
Yeah, sure. So, as Sir said, I think the most important thing is to have a pharmacological and a non pharmacological approach when it comes to tobacco cessation. As we understand that the addiction levels are so high, almost as high as how it would be with cocaine and heroin. So, talking about the non pharmacological interventions, we follow something called the 5 A's. So, starting with asking the individual about their tobacco consumption history. So, what age did they start? Why did they start? Now, what is the frequency? What is the quantity that they use? And trying to gather all of this information in order to help them further. So that would be the first step. And then we would advise them. So advising them, saying that it is most crucial for them to quit smoking at this point, and we're all here to support them and provide them means to cope with the same. And then we would move on to assessing. So assessing, we would have two things here. One would be assessing their level of nicotine dependence, and the other would be to assess at what level of change they are at. So assessing nicotine dependence, we have a test, the Fagostrom test of nicotine dependence, which has around 6 questions, and that will tell us what their dependency level is. And right now we don't use the term addiction anymore due to the stigma that it carries, but we do say substance use disorders, which has a couple of criteria that an individual needs to meet. So here it would be things like having a constant craving, trying to do anything that they can to obtain the product, having disruptions in personal, social, occupational aspects. It disrupts their daily functioning as well, and multiple other criteria that they need to meet. So once this is done, we try to assess if they are in the pre-contemplation stage or if they're in the contemplation, preparation, action, or maintenance stage. And once we have an assessment of this, we move ahead and assist this entire process for them. So the first would be to set a quit date within the next 2 weeks since we start the cessation. And when we do the same, we ask them to inform their family members, tell all their relatives that they will be quitting and they would need the support. Put away all tobacco products away, be it lighters, matches, ashtrays, whatever it is, put it all away. And we also inform them about what could be the possible challenges that they'll have to expect, what could be certain triggers that they have. And then we finally help them arrange all of these, coming up with a quit plan. So most commonly cognitive behavioral therapy, CBT, is used. So in the cognitive aspect, we focus on things like thought reframing and thought challenging, coming up with those kind of aspects. In behavioral, we have things like delaying but drinking water, distracting, a lot of other techniques used here. Relaxation and mindfulness techniques also play a very big role. So I think comprehensively using all of these things along with pharmacological interventions would make a difference. Thank you.
Thanks so much, Praniti. So, in summary, we understand that lung cancer, yes, is a very challenging disease, but there are options and they are very reasonable, concise options. Every patient is treated uniquely with precision oncology, and therefore, we always have multidisciplinary mode of managing them. And today, we had all these specialists who sit with us when we take decision. And I thank each one of you for joining us today. Thanks so much.
Prevention is better than cure.
And yes,
The take home is almost most of the cancers are caused by smoking. Prevention is better than cure. So don't smoke. And if you are smoking, wake up and stop it. There is nothing like in between reducing smoking. You stop it. And lastly, if you're a smoker, you are not asthmatic, your cough is not going, better go back to the doctor quickly. Let him decide a CT is required or not.
Well, as one of the two non-oncologists sitting here, I would like to give this message. I have seen an incredible journey of oncology in the last 20, 30 years. People that we would say, go home, there's no hope for you, just go home, relax, let the cancer take its course. This is not the situation anymore. I don't care if you're 20 or 80, please try and get the cancer diagnosed. Many times I have families come to me, oh, he's old, he's sick, let's not do it. Why are we doing this? But if you see the earth-shattering change we see in some of these patients, it is totally worth the effort. We have people who would have been gone in 6 months, live 5, 6 years now, longer, great quality of life. They come and thank you every day for pushing them to do it. So if there is a cancer, please at least get evaluated, know what your options are, because there's a very good chance you are going to have a very good option to treat. As a person who's been taking care of cancer patient, co-managing them, I can tell you that it is totally worth it at this point.
excellent. Thanks so much.